So at this point, it's my privilege to introduce our second speaker, Stacey Connolly, who will be providing her perspective on the diabetes educator role in addressing time and range in the clinic. Stacey A. Connolly is an experienced CDCES certified diabetes educator at the Joslin Diabetes Center in Boston. She leads the technology team, which educates and assists patients and staff in using continuous glucose monitors and insulin pump therapy. She has also developed curricula for education in the use of continuous glucose monitoring for professionals and patients, and she provides direct patient care and education to both individuals with type 1 diabetes and type 2 diabetes. Prior to working at Joslin, she spent many summers working at diabetes camps, which grew her passion for the young adult population with type 1 diabetes, where she specializes in the transition from pediatric to adult care. Stacey is a graduate of Curry College with a Master of Science degree in nursing. So we're excited to have Ms. Connolly with us today to share her experience. Welcome, Stacey.
Thank you both, and thank you for the opportunity to speak on the educator perspective here. I feel like if you want to advance the slide, I believe that successful use with CGM starts at that initial training. As you train the patient and educating them on just the basics of CGM use, understanding the difference between interstitial fluid versus capillary glucose, sensor lag, and calibration. Other topics that we discuss with the patient are going to be about, setting the high and low alerts, the rise and fall rates. I feel it's important to find a balance between those because if you set maybe the alerts to the ranges too narrow, the patient can get over alerted. If you set them too wide, the patient may not get any alerts at all. I think it also brings the opportunity to discuss what the patient's glucose target ranges are as you're setting those alerts. During the initial visit, we also start to talk about and access reports and what time and range is introduced. The educator also offers support with coping and problem solving with new technology and concepts. I was asked to describe how I actually talk about time and range with our patients, and I feel like it's the easiest way to go with it, or the first step I say is I talk about the A1C. I say to the patient, you know what your A1C is, right? It's that average glucose, and then I go from there and say, well, time and range is more about how you get that day-to-day variability. It offers a much bigger picture of the day-to-day management. And this comparison usually hits home for patients. They can usually kind of start to identify that and think about it. I also try to provide education around the meaning of what the time and range means, and then define those standard target ranges of 70 to 180 when appropriate, because as we know, maybe that is not for all populations. Those may not be the standard. I feel like while discussing time and range goals, it can also help you and your patients establish their goals for time and range. If you can advance the slide. I love this example. As we can see, CGM reports can identify glucose patterns and variability. They assist patients in that deeper dive examination, which can also reveal additional educational needs. In this patient example, as we can see, or as we know, patients can see more hyperglycemia. Well, that information is helpful. A very common response to that is to take more insulin, resulting in hypoglycemia. As we do report analysis, it really allows the provider and the educator to identify behaviors and set and see the percentage of time and range and the percentage of hypo and hyperglycemia events. Often, this can lead to an open discussion of what the patient does think may be the cause of either the hypos or the hypers. Is it a behavior that they need to change, or is it an insulin dosing that they may need to change? So additionally, you have the chance to re-educate patients on insulin action, the timing of that. Are they pre-meal bolusing? Are they post-meal bolusing? Is that causing highs and lows? The food complexities that we see, because, as we have patients carb count or take insulin for that, but, sometimes food isn't always as straightforward as we would like it to be. Exercise, then looking at insulin on board. And again, all of these things, you're educating them to try to have them increase their time, their time in range. I also think it's important to try to focus on what works with the patient as you're looking at different reports, and that may be a multitude of the reports, but take, for example, the daily view. If you see a day where they're spending most of their time in range, asking the patient, hey, what did you do this day that was different from maybe another day? And how can we replicate that? I think you need to also remind the person with diabetes that to aim for improvement, not perfection. This was definitely a tagline that one of our former colleagues from Joslin used to say. If you can advance the next slide. This actually comes from the Association of Diabetes Care and Education Specialists. It's a way for the certified diabetes educator to work with the patient in terms of looking at the data. So you can see data download, they're assessing safety, that time and range, areas to improve, and then of course an action plan. If you can advance to the next slide. I think some of those take-home messages are encourage the use of a CGM. Encourage the use of CGM when possible. Ensure that the patient has proper training and ongoing education when using CGM technology. You need to have a continued review of alert settings and patient response. Review and analyze that data with the patient, help identify trends for behavior change, and ensure that the patient has realistic expectations. And as I previously mentioned, really trying to drive home that you're aiming for improvement, not perfection.